Good afternoon, everyone. This is Kevin McGinnis, welcoming you to another session of the Community Paramedicine Insights Forum, this for September of 2017. I'm here with my colleague, Gary Wingrove, who is running everything in the background for us today. We have a great session lined up for today. And I just wanted to add that I sent out to our list today that Friday is Fall Prevention Awareness Day. So if there are those of you that have programs around falls, you might want to be aware of that activity going on. This afternoon, I'm pleased to introduce Karen Pearson, who is a policy associate at the University of Southern Maine Muskie School of Public Service. She's an active researcher in the Maine Rural Health Research Center and also serves on the Flex monitoring team nationally. She brings a great deal of experience in rural health research to her role, and one of the things that she has worked on of late is the Maine EMS Community Paramedicine Evaluation Project, and we'll talk a little bit more about that project in just a moment and the history of it and whatnot. It is my pleasure to introduce Karen on behalf of the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research, bringing you today's program. Karen Pearson, welcome.
Thank you, Kevin. Thank you, Gary. It is an absolute pleasure to be with you and to talk with all of you who are on this webinar. This is a great opportunity to talk a little bit more about the Maine Community Paramedicine study that we conducted back in 2015. And my hope is that this time together with you today will provide the basis for conversation about statewide community paramedicine programs and also about issues that rural community paramedicine programs encounter. So a little bit about how I want to structure our time together. I'd like to have Kevin jump in just a little bit to give us a brief history of community paramedicine in Maine. He was a driving force for that. And then we'll talk a little bit about the legislative background that enabled this statewide program, the definition of community paramedicine as it's defined in the legislation, how we approached this study and what the state was looking for in this study, and then talk a little bit more in depth about the individual community paramedicine pilot sites. We want to look at their implementation, the types of services, data collection efforts, and we want to touch briefly on cost issues. And before we actually get into the successes and challenges, I want to talk a little bit more in depth about one of our community paramedicine pilot sites to give you a little bit more robust information about that and how they developed and implemented their program. And then we'll talk a little bit more about lessons learned. So Kevin, at this point, I would like for you to kind of share with all of us some of the drivers and the impetus for community paramedicine in Maine leading up to the legislation. So this is your opportunity, and then we'll just jump right into the legislative background after that.
Sure, my pleasure, Karen. This dates back in Maine, community paramedicine dates back in Maine to about 1999 when I was actually the chief of an ambulance service in western Maine that had bases all around that part of the state. We had approximately 1,400 square mile area served by 5 bases, all with paramedics. And one of the things we wanted to do was keep our paramedic skills up in the face of lower call volumes. And so we tried doing a number of things to accomplish that. But one of the things that we thought we might do would be to have our medics actually staff some of the rural health centers up in that area, and so and do primary care between ambulance calls, and therefore keeping their skills up a bit better through direct application. And so we started talking about that within the hospital, which was the umbrella for these ambulance services. And at that time, that hospital actually was talking with the Robert Wood Johnson Foundation about another project, and they sent some site reviewers to the hospital. And kind of as an aside, we got talking about this program to use paramedics to do primary care. And they invited us down to actually propose to turn that into a nationwide funding project or challenge project for research programs or service enablement programs and research as one competitor for that funding. And so we ended up doing that, putting a proposal together, went to New Jersey, and laid on the table something we called Community Paramedicine, for lack of any better name, and suggested community paramedicine program development as we know it today. Unfortunately, the other competitor for funding, service enablement funding, was ED overcrowding at the time. And that was a very popular topic and actually won the day. So we came back to Maine, and we didn't end up going anywhere at that point with that program, although we did start to play with having paramedics doing other types of things in association with the calls that they had gone on, some follow-ups and that sort of thing. We then go to around 2004, when the Rural and Frontier EMS Agenda for the Future was written by the National Rural Health Association, which prominently featured and suggested community paramedicine as a means for improving rural EMS capabilities as well as rural health capabilities. And that kind of gave community paramedicine around the country a kick in the pants forward. In Maine, it had the same type of effect. There were a number of people thinking about doing community paramedicine types of things. We had some meetings with folks at different services who were interested in doing something of that sort. And so Maine EMS, Jay Bradshaw, the state EMS director at the time, invited us to meet with him and have some conversations about where this would head. Long story short, we created, in partnership with the State Office of Rural Health, a position of state community paramedicine coordinator, which I ended up stepping into for a while. And we were kind of in a good place at that point to do a statewide pilot project, because we did not have any active local programs going, but we had a lot of folks that were interested in doing that. So we created from the ground up a community paramedicine project, and it had a couple of parts. The first part was having statewide meetings on community paramedicine, introducing the concept around the state, trying to anticipate where the opposition for that might come from and that sort of thing. And then actually creating an application process, a program evaluation process, and we had the ability to build in certain things we really believed in, like adequate medical direction from a primary care type physician, program evaluation and patient tracking, and those sorts of things. And some of those things worked well, and some of those things didn't work so well, but that's what we're here to talk about. Subsequently, there were, I'm going to let Karen take on from here. We did end up with a series of 12 pilot programs. Karen, you want to talk about the legislation?
Great. Yeah, thanks, Kevin. That's a wonderful synopsis of this. And I think one of the things that I want to highlight from what you said, too, is that the stakeholders and potential funding sources were identified as sort of an outgrowth of all of these conversations that you had. And a steering committee and a task force, was formed as well. And those are essential components to moving a program like this forward. And so in 2012 then, the Maine legislature was agreeable and passed LD 1837, which granted the authority for the Maine Board of Emergency Medical Services to approve up to 12 community paramedicine pilot sites for a duration of 3 years. And again, this was just a pilot program that was authorized. And I think one of the important things here is that while it provided the authorization for the EMS board to approve the applications that Kevin talked about were being developed and in process, it did not actually provide any direct funding for the pilot site. So all of the operational costs, the development costs, implementation costs, all of that were to come out of the individual pilot sites. And I would say also, in looking at this as a statewide program, funding only as it was already in the EMS budget. There was no additional funding given to the state to provide this kind of oversight. So we did have 12 community paramedicine pilot sites, and a couple of those were combinations of a couple of ambulance services. So 12 pilot sites, but 14 services involved. So we then conducted our study in 2015 with these 12 pilot sites, and at that time, during our study, and even just in some conversations with the pilot sites after our study, there's this tension. It is a pilot site. How can we move this out of pilot status? It did place a certain level of expectation and stress on the pilot sites and the state to prove the value. And so what we found was that in 2017, there was this push, this emphasis at the state level, at the ground level, to take these pilot sites and move them out of pilot status and into more of a permanent category. The governor did not approve this at first, so the legislature did pass this, overriding the governor's veto. So it would be incredibly interesting to follow up with these 12 sites and the additional new sites that have come along to see what impact this change in legislation has had. Actually, let me go back one. Oops, sorry. I want to talk a little bit about how community paramedicine has been defined in the authorizing legislation, because I think it's very important to understand the context and the constraints that may be placed as we go along. So as defined by Maine's authorizing legislation, the practice by an EMS provider, community paramedicine, is an out-of-hospital setting providing episodic patient evaluation. And I put this in bold type because this is a real key element. It's episodic, it's not ongoing. This has been an issue at the state, that this is episodic patient evaluation, advice, treatment directed at preventing or improving a particular medical condition within the scope of emergency medical services provider or as specifically requested or directed by a physician. So we are looking at this episodic patient evaluation or this treatment, episodic treatment, as directed or referred by a physician. So as Kevin alluded to earlier, as he mentioned, each service in the pilot program was to include a primary care physician and an EMS medical director. So when we were granted the contract to look at the community paramedicine program to evaluate, and then we use the term evaluation very loosely in this study, that was in 2014. These pilot sites were authorized by the legislation in 2012, many of them working to develop and implement their programs, their pilot projects. So 2013, some of them getting up and running. 2014, were awarded the contract, and in 2015, we conducted the bulk of our study. We approached the study based on the RFP that the state put out. What they were looking for was data collection by the community paramedicine pilot projects to be able to see the impact and the cost of community paramedicine upon the community as well as to the pilot sites. Ideally, the state EMS office wanted to see if there was any reduction in excess ED utilization and hospital readmissions, or even any kind of reduction in healthcare costs by providing community paramedicine. We realize there's no causality with this kind of project, but we wanted to see, does does community paramedicine, do these services that are being provided, do they have any impact on reducing excess ED utilization or hospital readmissions? But again, I want to say that for many of the pilot sites, when we came in to look at them and to talk with them, it was what we thought was more of a midpoint evaluation, but for some they were just getting started. So as we'll discuss in a little bit, outcome data really was not available. So what we did for the study is we looked at all the pilot site applications. We monitored, or we looked at the number of runs that were identified as community paramedicine visits or runs in the Maine EMS run reporting system, the MEMSR system. We interviewed at least 2 or 3 people at every pilot site to try and get the perspective of the PCP, of the community paramedics, of the EMS chief. We also talked with those involved at the state EMS office. And as part of this, in terms of trying to look at the costs, we developed a cost worksheet for each of the individual community paramedicine sites, and we'll talk about that in a little bit too. And I don't know if you can see this. This is a very tight slide. This is a logic model that we developed as a guide to visually portray the goals and strategies of the statewide community paramedicine program. The logic model shows the state EMS level of input as well as those of the pilot sites and their stakeholders and community partners, including the PCP. The outputs, as we go, the inputs and the strategies, the outputs concern the level of data collection and the number of referrals, because those were the key points that we thought we could actually track. For the original 12 pilot sites, all of the community paramedicine visits were to come from a referral or to be signed off by a primary care physician. So this was a critical component. Currently, at this point in the community paramedicine program, I think we're still looking at the short-term outcomes. And hopefully for some of the services, moving toward data to show more of the intermediate outcomes of their project. And the short-term outcomes we're looking at, was there an increased understanding of community paramedicine services on the part of the patients? Was there satisfaction? On the part of the healthcare providers, was there increased familiarity with the community paramedicine model and a readiness to refer patients? And at the state level, looking at short-term outcomes, was there an increase in the amount of data reflective of community paramedicine visits entered into the run reporting system? And long-term outcomes, again, our goal is, as always, to improve population-based health outcomes. But through that, we're looking at strengthening the healthcare system and enhancing the EMS agency performance and accountability as well. So what I'd like to talk about next is what kinds of services did the community paramedicine pilot sites provide? This, again, it was based on a community health needs assessment in collaboration with stakeholder and community partners, and we'll see on the next couple of slides sort of an overview of the types of services, the variation, and the commonalities. And one of the things in thinking about services of the pilot sites and looking at the based on community health needs assessment, something for states to consider for new community paramedicine applications is asking, will it be helpful to have a formal community health needs assessment? It was not a requirement for these 12 pilot sites. It did not require a formal community health needs assessment, but it did require a description of the community health needs that they would address. So the question is, would it be helpful to have a formal CHNA, or would it be a burden to the EMS agencies to have that provided? And for those that are affiliated with the hospital, has the hospital already conducted a CHNA, Community Health Needs Assessment? And does it align with what the EMS agencies are seeing? This is just a quick chart of the major types of services that were provided by the community paramedicine pilot sites as gleaned from their applications and our interviews in 2015. What you can see, and it's ranked in order from most down to least, and so what you can see is that Most of them, and what we'd say about 75%, focused on medication reconciliation and compliance, as well as diabetes assessment and follow-up treatment as directed. So what we see here in looking overall, a bigger picture, is that the community paramedicine services were primarily geared toward patients with chronic diseases with the goal of preventing readmission. And I want to bring up a point about home health in all of this, and we can talk about that a little bit further too. Home health, for the most part, had good relationships with our community paramedicine pilot sites. Most of them talked with them. They had them on their community partners, their stakeholder groups. There was a good connection in terms of what kinds of referrals and what kinds of services would be provided. And many home health agencies relied on the community paramedicine services to get to the patient's home within 24 to 36 hours post-discharge, something that for some of the home health agencies they were not able to do. Data collection is a key element for any community paramedicine program. What types of data are needed to provide a baseline to establish the business case for the sustainability of community paramedicine? In addition to cost to the community paramedicine program, are there specific data points that should be collected to show impact of the community paramedicine program on the community, on the patients, on the providers? These were some of the questions that we asked of the pilot sites as well as of the state EMS office. So data collection included the MEMS, or the Maine EMS Run Reporting System, which has changed over now to what's called MEFRS, which is the Maine Fire Incident Reporting System. And so we'll show a little bit of data that shows some of that overlap. But how is community paramedicine, how is data collected at a statewide level? How are those runs or CP visits tracked? And the connection, is there a connection with EMRs? There is a need for a standard set of community paramedicine data points. And the goal, when we first met with representatives from the pilot sites, the goal is to be able to connect runs with electronic medical records or patient charts. United Ambulance and Mayo Hospital, at the time of our study, were in conversation with Health InfoNet to address this, and that's something that I would like to follow up, but at this point I don't have current status of their negotiations and conversations. In 2014, just prior to when we received the contract, we did meet with the representatives of the pilot sites. They were gathered to talk about some of the data elements that they felt needed to be addressed and how to make sure that the MEMSR system was modified to be able to provide input on community paramedicine visits. So there was a lot of discussion in 2014, not a lot of resolution or action. So as we got involved in the project and meeting with the individual pilot sites, we set up a webinar for the pilot sites on data collection strategies, specifically geared for community paramedicine, and it was led by Matt Zvatsky of MedStar in Fort Worth, and I have a link to the presentation. It was very helpful for the pilot sites. I think it was a little bit overwhelming for them because many of them were just starting to get going. Low volume was an issue. So data collection is an issue, ongoing issue for the community paramedicine pilot sites. We met again in 2016 to restate the need for standard data points to collect, and again in 2017 we met with the community paramedicine pilot site representatives and some of the new EMS agencies that were starting their projects. When we met, it was just prior to the passing of the 2017 legislation, which moved them out of pilot status. So when we met, there was still a little bit of uncertainty about the sustainability of these pilot projects. This is a chart, and this is in our report that we submitted to the state. This data is from the Maine EMS Run Reporting System. It's a total of all runs that were recorded by the 12 pilot sites, And as you can see, Maine's total volume is small. I mean, this really reflects the rural nature of the program. One of the pilot sites, United Ambulance, accounts for the majority of the quarterly visits. For example, in quarter 4 of 2015, of the 516 visits that were recorded, I believe United Ambulance had about 198 of those. So you can see, the total volume is very small, and that is an issue to be taken into consideration. This is an updated chart. This is a combination of data from both the Maine EMS run reporting system and the new Maine Fire Incident Reporting System. It's a total of all runs that were recorded by the pilot sites. The updated stats from the state show a slight increase in community paramedicine runs in 2016, ranging from 533 to 576 per quarter. But it should be noted that there are a couple of variables that have changed since 2015. And one is that there are 8 new sites participating in the community paramedicine program. 2 of the original 12 sites are no longer participating. And so we have a total of about 22 pilot projects. Well, I guess they're not called pilot anymore. 22 community paramedicine projects in the state. The other variable in this data, in looking at this data, is the transition from the Maine EMS run reporting system to the Maine Fire Incident Reporting System. And not all services have made that switch. Additionally, one of the community paramedicine sites has shifted their focus somewhat and are more selective about the visits that they make for community paramedicine. So for them, they show a reduction in the number of CP visits, but it's not for a lack of referrals, but more about the need to refocus in order to sustain the program. So that's something that you don't see just in this chart, but it is a factor that needs to be considered. So we've talked a little bit about costs, and the next couple of slides are going to show a cost avoidance formula that can be used to help determine the value of the community paramedicine service. And I've listed the source of where we gathered some of our information on how to develop this cost avoidance formula. One of the things that should be noted is that pre- and post-enrollment data is very, very helpful in showing the impact and value of community paramedicine programs. So here's a formula on cost avoidance formula of savings per patient. And again, this formula was developed by MedStar. I think here, in looking at putting together this kind of formula, the key pieces are to have a defined criteria for determining avoided transport, tracking enrolled patients, and again, that enrolled having a baseline pre-enrollment and post, and having updated cost data for emergency department visits and ambulance transports. Our data for the emergency department cost was obtained in 2014 from the Maine Health Data Organization Health Cost Calculator. It was available on their website. That cost calculator for Maine is no longer available, so if we were to redo this study, we would need to contact the hospital directly for the cost, and I believe that's one of the suggestions that's made for other programs in looking at cost to contact the hospital directly. So cost avoidance formula does not actually or may not actually result in realized cost savings, but understanding what the numbers are and plugging in this kind of a formula, it shows the value of the community paramedicine program. So for this example, we're looking at the average transport cost, the ambulance cost, and the ED cost, the number of transports avoided, and I would strongly encourage sites to have a very clear definition and the criteria for how an avoided transport is determined, and then the number of patients enrolled. So you plug in the numbers and you can see a total savings, and then dividing that by the number of patients enrolled, a savings per patient. Applying this same kind of formula for hospital readmissions, again, the key is having defined criteria for determining what constitutes an avoided ambulance transport. and hospital readmission cost data would come from the specific hospital. So in this case, we used the Maine Health Data Organization data for hospital admission data for Medicare beneficiaries, but the facility costs only. So actually these costs would be underrepresented. So I want to talk a little bit about some of the community paramedicine pilot sites, looking at site-specific costs. This was of interest to the state EMS office. How much does it cost to run a program like this? How can we budget for this? How can communities budget for it? You know, what goes into making this a cost-effective program? So we developed a cost worksheet and sent it to each of the 12 pilot sites with the goal of trying to provide quantifiable data for communities to determine the overall cost to run a community paramedicine program in order for them to have hard data, well, not even hard data, but have data, cost data that they can take to their town manager or that they can use to help market their service. So we looked at personnel costs, we looked at administrative costs, we looked at training costs, because we know that in order to be a community paramedic or to have that kind of role, ongoing training needs to be provided. We looked at operational costs, vehicle costs, charged for ambulance transport, medical supplies, and reimbursement rates. So we did receive responses from all the 12 pilot sites. Not all of them were complete, and so we were not able to formulate an overall cost savings for each site. I think there may have been some confusion about the nature of the cost worksheet, so this would be an area for future discussion in data collection conversations. Before we get into challenges, what I'd like to do is to talk just a little bit about one of the community paramedicine pilot sites that we spent a little bit more time with, a little bit more in-depth study, and this is written up in the journal article that we published as well. I think by talking about this particular ambulance service and what they did for community paramedicine, we can have a better idea of what some of the implementation challenges were, what some of the successes were, a little bit more about how to build for sustainability. So I want to talk a little bit about the United Ambulance Service, and it's based in Lewiston, Maine, which is one of our larger cities in Maine. And the United Ambulance Service is one of Maine's largest providers of medical transportation services, and they serve both rural and urban areas in Androscoggin County. The top areas of concern for them in terms of health of their patient population were obesity, asthma, substance abuse, diabetes, and heart failure. And currently now they are focusing on the asthma and heart failure. One of the interesting things about United Ambulance is that their community paramedicine program was built upon a program that they had started a couple of years prior to becoming a community paramedicine pilot site. It was their home visit program. They developed this as a way to reach residents in their catchment area who routinely use emergency medical services for non-emergency issues. And also this was a patient population that had limited access to social services or health care resources. So their goal in providing this free service, funded by their ambulance service, but free to the clients, was to ensure quality pre-hospital care through the appropriate utilization of EMS services for these vulnerable populations. Their goal was to decrease unnecessary EMS transports and to promote preventive strategies and outreach and connecting people to primary care providers. They also, because they are owned jointly by two hospital systems in the area, they were focused on collaborating with their hospital partners to create a systematic approach to prevent 30-day readmissions for these vulnerable populations. And then it was very important to them that they create a program that avoids the duplication of existing services. For example, they were not going to duplicate community care teams or home health, but they would work with these community partners to meet the needs of a vulnerable population in their area. United's Community Paramedicine program is staffed full-time. They created a position, Prevention and Wellness Coordinator, and this position also received Community Paramedicine certification through the Colorado Mountain College Community Paramedic Program. This was very important to their service that they have this kind of recognition for the kind of services that they were providing. Referrals, again, with the community paramedicine pilot sites, referrals needed to come from a primary care physician. And so in their program, the referrals can come from a variety of sources, such as home health, community care team, the hospital. There's a cardiopulmonary rehabilitation center, in the area that works closely with United Ambulance. But ultimately, the primary care physician needs to sign off on the order for a community paramedicine visit. And again, being owned by the area hospital systems, United Ambulance was able to capitalize on that affiliation by portraying their community paramedicine services as an extension of the hospital. They were also very involved in a community stakeholders group. It was a coalition of 10 to 14 area agencies, and so that connection of these healthcare organizations and community partners provided a consistent messaging that they were able to make to the patients being discharged and to those being visited by a community paramedic. United Ambulance tracks the number of EMS 911 calls and transports for patients that they enroll in their community paramedicine program. And what they do is they then compare that to the number of 911 calls and transports for those same patients prior to enrollment in the program. So what they were able to show by tracking this and having the enrolled population and showing the prior data for hospital admissions, ED visits, and EMS 911 calls, they were able to show that there was a reduction in all three areas for their enrolled patients. United Ambulance also does a very good thing in having case notes to collect data about their community paramedicine visits. And so having these case notes, which it's very difficult to do this in the Maine EMS run reporting system, but having these case notes as a documented way of tracking the kinds of visits and the outcomes is a good way to also try and track costs. And so one of the case notes that United Ambulance had was for a woman who was needing community paramedicine visits on a weekly basis, and she had been to the emergency department 8 times, 7 by ambulance, in the 12 months prior to enrollment in the community paramedicine program, and admitted once to the hospital. But since enrollment, she called 911 only 4 times, had no hospital admissions, and so they were able to show a 50% reduction and, more importantly, a cost savings to the EMS system. But if I can go back just for a moment to show you this cost avoidance formula, calculating cost savings according to these formulas can be actually very complex. It looks very simple. You just plug in the numbers. But, a simple formula is to take the average hospital payment, multiply by the number of hospitalizations avoided, and divide that by the number of patients enrolled. Actually, I think that is the next slide. According to the case notes for United Ambulance, in one of their situations, there was a patient who needed daily wound care treatment. And so this formula did not accurately depict the cost avoided. So over the course, here's how this scenario works out. Over the course of 45 days, the community paramedic was able to keep the patient out of the ED and the hospital for a stretch of 18 days. The patient was transported by ambulance to the emergency department and briefly hospitalized for 4 days. After discharge, the patient was seen at home for 11 more days before being transported to the ED once again, returned home on that same day. The community paramedic saw him for another 6 days. He was in for lab work in the ED and returned home that evening. The community paramedic continued daily visits, and the patient did not return to the ER or the hospital during the remainder of this 45-day period. So we have a lot going on back and forth. We have some ambulance transports, we have some transports avoided, we have some hospital admissions, we have some hospital admissions avoided. So for this patient who had been hospitalized over 70 times and was a frequent user of the EMS system in the ED, the value that the CP provided by seeing the patient at home needs to take into account not only the number of hospitalizations avoided, but also the number of ambulance transports and ER visits avoided. So it does get complex, and the burden is on the EMS service to try and track these visits and these avoided transports and admissions very carefully. So let's talk a little bit about some of the challenges. Obviously, reimbursement is a huge issue, and we know that the Maine EMS office is working with Maine Care, our Medicaid system, and also in conversations with Humana about reimbursement for community paramedicine services. It is a slow-moving process. Challenges are that the data tracking system at the state was not designed for community paramedicine, and the challenge still remains how to make it viable. There is concern about physician buy-in. It is an ongoing struggle to get the complete PCP buy-in for CP referrals. And as we talked about, gathering reliable cost data is difficult, and so there is a need for a refined data collection tool or data collection system. So those are big challenges. Those are challenges that are not specific to a rural area. They are challenges with any community paramedicine pilot site, or whether or not it's a pilot site. It is a challenge, but there are successes. And the successes that I note here are those that were, they're kind of high level. They're from our study in 2015. We are now 2 years out from that, and so most of the successes that we heard about were in anecdotal form, but those stories overall point to community collaboration, patient engagement, and trust, and those are huge successes in trying to build a new model of healthcare delivery. There was an increase in the number of community paramedicine runs reported. The referral system is a key component of a successful community paramedicine program. And so most sites developed a flow chart depicting the referral system and could refer back to that or use that as a guide for connecting with the primary care physicians, with the hospital, and with home health. Staffing time, Kevin mentioned this early on, to keep the paramedic skills up and to provide opportunities for use of those skills during downtime. This was a success for most of the pilot sites that we talked with. And training was recognized as an important component of a community paramedicine pilot site. Training, whether it was local, working with hospitals and doctors in learning new skills about assessment and treatment for those with chronic diseases, or whether it was funding by the EMS agency to be able to send the paramedics or the EMTs for nationally recognized training. These were regarded as important components of the pilot sites. And the success was that what we heard was that there was a positive perception of community paramedicine by the community. Those relationships that were developed were incredibly important. So lessons learned. We found that sustainability was not dependent on organizational affiliation. Our thought was that if a community paramedicine pilot site was affiliated with a hospital, there would be a higher percentage of those that would be sustainable. But that was not actually, organizational affiliation was not actually a major driving force for the sustainability of the program. Sustainability is primarily a financial issue for these community paramedicine projects. Of the sites that said they would be continuing, because that was one of the questions we asked, 3 are municipal, 1 is a private service, and 2 are hospital-based. So again, the organizational affiliation was not a driving force. And we were very pleased to hear that one site that had indicated to us that their program was most likely not sustainable had found momentum and had turned it around and is continuing. And we have new sites that have come along, so these are well worth tracking. Lessons learned, so sustainability, a need for better data collection, a need to determine cost savings. And because the community paramedicine sites are looking to connect these patients with their primary care physicians, a better PCP buy-in is needed. Patient satisfaction surveys was an area that we had some interest in finding out a little bit more about, and so did these services. There's not a standard patient satisfaction survey that was implemented across the sites or even individually, but there was definitely high interest in doing so. And a lesson learned in terms of a statewide program is that there is a need for resources to create a statewide community paramedicine infrastructure. So the conclusions from our study, and these are just minor conclusions, is that the Maine EMS Community Paramedicine Pilot Program can be a model for additional CP pilot sites, and we've seen that happening. But it also can be a model for other states considering a statewide community paramedicine program. And solutions to the issues that were raised in the lessons learned, solutions are possible with guidance from the state office and a good healthy exchange among the, what I would not call pilot sites anymore, but a healthy exchange discussion between the community paramedicine sites. So I have a link to our full report and then a link to the article that was published as an outgrowth of that report. And this is my contact information, so if you have any questions or want more information, I'm happy to hear from you. So that's what I have for now, and Kevin, I'm going to have you take it back.
Thank you very much, Karen. That was fascinating. As close as I have been to the process here, I've learned a lot from your evaluation program. We will open this up for questions, so I'm going to ask Gary first to unmute everybody.
The conference has been unmuted.
Great, and we do have, we had a couple questions while the program was going on. The first was, why did the governor veto the legislation in 2017? And that has nothing to do with community paramedicine. It has everything to do with it has everything to do with tensions between the governor and the legislature. And interestingly, the governor actually was very, and the Medicaid program have been very supportive, although it's taken a long time to have the Medicaid conversation. It would have actually been resolved a year ago had the governor been allowed to do what he wanted to do, which was take his rainy day fund and apply it to initial funding of the Medicaid program for CP. He was, again, there were issues with the legislature, and so that perennial battle has created some issues for us.
Right. I think that's a very good way of putting it, yes.
Then the second question was about the reaction of nursing and home health agencies, and did they see community paramedic programs as competition for funding? I can answer that fairly briefly and say that we've seen a range of reactions. Early on, yes, there was some resistance from home health, who basically said, we already do this, why do we need somebody else doing it? And then in various locales, further conversations have been had which essentially realize that not every patient is qualified for home health, and that there are patient needs outside of those who are eligible to be enrolled in home health. And in those communities, home health has actually grown into partnerships with community paramedicine. The United Ambulance project is a great example of a program that's working very closely with its home health agency. And in fact, there are places in the state of Maine where home health dispatches community paramedicine, and we have seen cross referrals between home health and community paramedicine. I don't know, Karen, if you have anything to add to that.
Just that that was a question that we raised when we interviewed all of the pilot sites, is what was their relationship with home health and other healthcare organizations in their community. And they told us that, and we in our site visits as well, we heard that the community paramedicine pilot projects had as part of their protocol to check to make sure that if they were being referred to go out and visit the patient, that the patient was not already eligible for home health. So that was a consideration, and I think they work very closely with the home health agencies.
Great. So we'll open this up. If you have a question that you'd like to pose, Karen, please just speak up. And we have a quiet audience today.
Well, it's foggy here in Maine, so maybe that's part of the reason.
Well, Karen, I'll give you a shot at a last closing comment. I really do appreciate your being with us today.
Well, thank you. I very much appreciate this opportunity, and I would say in closing, I think that there are a lot of opportunities for future research in this area, and I would strongly encourage those research centers who have an interest in this to see if they can seek funding to be able to pursue this, because it helps provide that evidence base that will move community paramedicine forward.
No question about it, and it's that proof that is going to be so vital, to either prove or disprove community paramedicine as a concept, a useful concept. So I want to thank Gary Wingrove for his support today again, Karen Pearson for the excellent program, and to note that we will not have a program in October because that would be during the holding of the International Roundtable on Community Paramedicine Conference in Las Vegas, the 15th, 16th, and 17th of October, I believe it is. So we will come back on November 20th with our next program, and we will see you all then. So, Gary, do you have any closing remarks before we call it a day?
I don't, but there is a question that just popped up in the chat.
Yeah, I just saw that too.
Okay.
Do you guys want to answer that? Is there a community size that is too small to sustain a program? My guess is probably not. It really depends on the community.
I think in my experience, that's true. And in fact, in the Maine projects, one of the services that you referred to was one that was in jeopardy and then came back.
Mm-hmm.
And what I'm thinking of, it was run by a volunteer first responder group. In fact, it was an ambulance service that had closed down, converted into a fire department first responder group, which has always sort of been in jeopardy because of a lack of members. And one of the things that actually buoyed this group up rather than caused it too much weight to keep going was getting into community paramedicine and having people get interested on a volunteer basis to do CP. And that was a very, very small community on one of our peninsulas.
Right. Excellent question.
Yes. Okay. Well, again, November 20th, we will be our next Community Paramedicine Insights Forum. So on behalf of the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research, we are pleased to have brought you this show. It will be put in our archives when our website is back up and operating, and I will certainly send out a notice that it's available for folks, and that way you can also gain access to those links that Karen showed to her report and to the journal article. So we'll call it a day and wish everybody a happy fall.
Thanks very much, all.